Hey, welcome to the Elle Russ Show, where we explore ways to get healthy, wealthy, and wise. With a combination of guest interviews and solo episodes, I hope you will be inspired and motivated to become the best of whatever you are. I'm Elle Russ, #1 best-selling author and subject expert with over a decade of helping thousands of people across the globe. Visit my website, elleruss.com, to learn more about free guides, masterclasses, online courses, and more. Enjoy the show. Today we have on the show Dr. Todd Bertoch, MD. He is a diplomate of the American Board of Anesthesiology and served as an anesthesiologist in the United States Air Force, has a ton of experience in both trauma care, pain management, and we're going to talk today about pain management, non-opioid potentials, all of it. So if you know someone who's suffering with chronic pain, something like it's long-term that needs to be managed and it's not, this might be the episode to send to them. Welcome to the show.
Thank you. Thanks so much for having me.
As you went through your life, you're getting into medical, what was it that interested you about getting more into and following the path of pain management?
It became clear to me as my medical training started that I was being drawn to the field of anesthesia, and part of the specialty of anesthesia is this focus on pain management, whether it's chronic pain management or acute pain management. And so when I first got out of my residency, my very first appointment was as a sole anesthesia provider at a small hospital. And so I had my own pain clinic, and I would treat people with all different kinds of pain. And I was actually serving, as you mentioned, in the military at the time. And I was treating the wife of a full bird Marine colonel. And I don't know if you're familiar with the military, but
isn't that the top of the absolute top, or admiral's next?
Yeah, it's tough to become a full colonel in the Marines. It's a small service, and anyway, they're a big deal. And I had been trained back in the 90s when opioids were the thing, right? It's the way we were trained back then is if someone's got pain and giving them opioids helps them live kind of a normal life, then you just keep giving them. And if they become resistant to them, you just give them more. And that's how we were trained, unfortunately. And so that's how I treated this patient. And then one day this Marine colonel stormed into my office, and honestly, I've never seen a Marine colonel cry, but he had tears in his eyes, and he told me that I had turned his wife into an addict. And that, of course, as you can imagine, hit me like a ton of bricks, and it changed everything. At that point, I started questioning what we were all being taught in medical school and in our residencies at the time. And from that point on, I was kind of all about pain.
That's brutal. We know of this opioid crisis. We know of the addiction. Someone goes in for knee surgery or even just like pregnancy, C-section, and they're given 100 pills, right? So hopefully they've shut a lot of that down with all the lawsuits and everything else. But we do think when we hear the word pain management, we definitely feel it's synonymous with opioid use. And I know you're challenging this perception you have, and you're working at SEN-XL, and you're doing lots of studies and things like that. But let's talk about that. I don't know what this is called, but before I interviewed you, I was reminded of a friend's mother who suffered with chronic pain in a variety of ways, and no one could really even figure out like why or what. But long story short, towards the end there, she would go in and they would she went to a very highly specialized pain management person, and they injected her nerves or something. It was a non-opioid thing that did provide her some massive relief. And I remember being like, ooh, this is interesting stuff. So let's talk a little bit about some of the promising non-opioid things, because I know people who are managing pain with opioids can't imagine probably another way.
Yeah. And there are other ways for a lot of people. For some people, and we can talk about this as we move forward, right now there aren't other ways, but for a lot of people there are. And some of the, I work every day with sponsors. We call them sponsors, basically developers who are trying to develop new non-opioid medications. And there's, new um, targets in the body that we're finding every day. Somebody finds some new way to treat pain. Pain's so multifactorial. There's just so many inputs to pain that, it's hard to um, find a one size fits all solution, but there's a lot out there that we're working with. Um, the things that you described before, um, injections, whether they're steroid injections or local anesthetic injections that can help people. We're implanting nerve stimulators where we put these electrodes into people's spinal cords, and we basically block the transmission of pain signals that are going from wherever they're having their pain to their brain, and basically turn off that pain with electrical stimulation in people's spinal cords. So many, we've done clinical trials here at Senexcel where we're actually doing injecting viruses with new mRNA or you know DNA, and trying to help develop new ways to have our own bodies create substances that will help with pain. So there's some really remarkable things that are going on, and there's still that subset of patients that we don't have an answer for, and those are the really hard ones.
Let's talk about something I don't think a lot of people know. Maybe they have heard. I remember when I heard of it, I was like, oh my God,
And
what?
I'm not sure if I lost you.
Oh, hi. Can you not hear me?
Okay, now I hear you. Sorry
Oh,
about that.
okay. Sorry. I was going to ask you, and I maybe some people have heard of this. I remember thinking, wow, this is awful. But I mean, I think it was most highly publicized with the actor Matthew Perry's death and his opioid use. And he publicly came out and talked about how basically, like, I mean, like it sounded basically like, oh, my colon just exploded and I had to go to the hospital. Like there was an awful situation there, right? He had to get colon surgery or his colon ruptured. It was an awful thing. I don't think people understand the long-term detrimental gastrointestinal organ affecting effects, right, of this. Can you tell us why and like what that was about, why that happens to someone who either long-term use or abuse? But can you give us the mechanisms? Like how would a drug like that screw up your system down there?
Yeah, so opioids have such widely distributed effects to your body that, they're amazing at helping some types of pain. I mean, I have kidney stones, and you can give me as much Tylenol and Motrin during a kidney stone flare as there is on Earth. It's not going to help my kidney stones. The only thing that will kill that pain is a strong opioid. And so, the opioids are super effective, and that's why they're still around. Um, but they do have a lot of side effects, and one of those side effects is that they can significantly decrease your gut motility, or your ability for your gut to move and move food through your body. And so people that are on chronic opioids have a lot of problems with um, inability to move their bowels, and that can result in bowel obstructions and surgeries that require that your bowels be removed. And so yeah, you know in addition to what we know about opioid overdose and losing the ability to breathe, and there are other issues with opioids that can be very significant.
Let me give you a scenario. I'm jumping in, getting involved in someone else's life here. I know someone who I know will never hear this episode. That's the only reason I'm bringing it up. Who terrible accident that crushed their foot when they were like 15, maybe now they're 50 something. A million surgeries, John Hopkins, this and that. Just, has to wrap his leg every day, been on the pain management, fine, functional, doing well, like living a good life, right? But, there's this consensus when you're on the outside where you're like, just cut it off, amputate the limb. right? Like there's a lot of people probably in the family that were like, why don't you just do this so that you can avoid this? Because it's useless anyway, won't get better. You've been down this road, it's been 30 years. That kind of argument. Yet it's very difficult to say to someone to take that away, right? Your limb. Then there's the argument of phantom limb pain, like that phantom pain. And that's sort of what I'm getting at. What is that about? Is that something to really be worried about? Is that something that it can be lifelong after even the source of the pain has been removed? Can you get into that? Like, because it seems crazy and strange to think that that could go on for too long. Um, then I also wonder in some of these cases with people, or how many do you think you see that they're so dependent on the drug at this point, even if it is for pain and helps, that again, it's like what not you can't imagine not being on it, right? You don't want to give that up. So there's two ends. I want to talk about phantom limb and then also that subtle addiction, right? Element.
Yeah. Well, yeah, let's talk about phantom limb and let's broaden that a little bit because what most people don't understand is there's there are two types of chronic pain. So you can have chronic pain because whatever insult or problem that your body's experiencing, maybe let's just use, for example, you have a slip disc in your back and that disc is pressing on a nerve that's coming out of your spinal cord and going to your leg. That's what, we call that kind of in layman's terms, sciatica, where you have that shooting pain that goes down your leg. The pain's actually being generated in your spinal cord because as your nerve roots are coming out of your spinal cord, this little disc that has bulged out is now compressing that nerve and it's causing that pain. Because that nerve feeds your foot or your leg, that's where you sense the pain. Your brain thinks that the problem is in your foot, your leg, but it's actually coming from your spinal cord.
I can
So
attest to this, by the way, happened
you've
to
got
me
that.
when that happened. I had a sciatic issue and I thought I had an ankle issue or a foot problem, and it wasn't. It turned out to be sciatica. So yeah.
Yeah. Isn't that amazing? So in those situations, you can have chronic pain because that disc just doesn't get fixed, right? Your body doesn't resorb it, or you don't have surgery to get rid of it, or whatever. If that disc continues to push on that nerve, you're going to continue to have pain. And once it hits 3 months, we call it chronic pain. Okay. There's another type of chronic pain that I don't think people appreciate. And, all pain starts as acute pain. But there's a term that we call chronification of pain. When acute pain becomes chronic pain and there's no longer the insult. In other words, the disc is no longer pushing on that nerve root, but there's a rewiring that occurs in our body, in our nerves, our spinal cord, and sometimes in our brain that allows us to still experience pain,
Mm.
even though the insult is no longer there. And that happens in many different types of conditions.
Mm.
Phantom limb pain is one of those, but it really is the same process where now you had this acute pain, something happened in your brain or your spinal cord has rewired, and now you're experiencing this chronic pain that really there's no longer an explanation for. That's something your body's doing to you. And that's the hardest type of pain. If you have a disc, we can take that disc out surgically, or we can do something to alleviate that. But once your pain has become chronified or, chronic, and it's no longer because of this particular insult, that becomes very difficult for a lot of reasons. First of all, it's hard to get a physician sometimes to believe that you're having pain because she or he can't see the cause.
Mm-hmm.
And that can be difficult for patients and for physicians. And we know how to treat certain types of pain, but this chronic pain doesn't really follow the same rules that we use for acute pain. So yes, phantom limb pain is real. You don't have to have your limb to continue to feel phantom pain. In other words, when you had your issue with sciatica, you could have cut your leg off and you'd still feel pain in your foot because that's where that nerve that's being pinched in your spinal cord, that's where that's a part of the body that feeds. And that's what your brain would sense as pain.
Let's talk about the promising non-opioid therapies that are being researched. You're doing clinical trials too, and I want to ask you about that. But what are some of the promising ones that are currently being either researched or implemented that you find to be like just really like you're excited about?
Yeah, there's a new target. Um, they're called NAV inhibitors or sodium channel inhibitors. That the sodium channel is a part of your nervous system that your nerve cells, when any impulse, whether it's painful or whatever, any type of impulse is sensed by your brain. Let's say, for example, you hit your thumb with a hammer. The nerves that go from your thumb to your brain to tell your brain you're experiencing pain, they act because of these sodium channels, or there's what's called an action potential that basically shoots that signal all the way up your nerve and to your brain, and your brain says, hey, I'm having pain in my thumb. Well, to make that process occur, our nerves have these little channels that allow sodium to rush into the cell, and it changes the polarization. It becomes like an electric circuit. And for example, local anesthetics like lidocaine, if you inject lidocaine around that nerve, then it blocks those sodium channels. It blocks the ability of those nerves to process that electrical signal back up to your brain.
Mm.
Um, so it would be great if we could just give that in an oral dose to everybody. Unfortunately, those sodium channels are also found in your heart, and all over. So if you just gave someone a big dose of that systemically or orally or something like that, then you'd stop your heart. And that's actually
I was going to be
something
like,
that,
well, let's stop the pain, but we don't.
yeah, stop that. But what drug developers are starting to find out is that you can isolate different parts of that nerve and different subunits of that sodium channel, and you can block just the subunit that is involved with pain and not affect your heart. And we've done a lot of recent clinical trials with some of those drugs and some derivatives of those drugs that are on the horizon coming out that really, I think, are hopeful to fill the gap between what we talked about, Tylenol and Motrin, or Tylenol and NSAIDs, and then the jump to opioids, where we can fill that gap between those over-the-counter medicines and the opioids so that people aren't necessarily having to jump to opioids. So those are really exciting. And then there's just so many interesting things coming up even with gene therapy, antibodies that people are developing to block certain pain signals in your body. Really amazing things out there. So while the opioid crisis is terrible and I deal with it every day, there's a lot of hope as well.
I don't mean to be a downer if the answer is going to go sideways, but did that person ever get out of their drug addiction that initially made you feel so awful?
Unfortunately, I live with that every day. I do not know because I
Mm.
got transferred out of that site later and wasn't able to follow up. But I will tell you, and you can imagine that when you asked me that question, this is the first thing that came to my mind. It haunts me almost every day.
Oh, I'm sorry. I didn't mean to be. I didn't mean to be a downer about that, but I guess that goes to show us, like, hey, opioids are, it also reminds me of, and I appreciate you kind of telling that story because a lot of doctors would be very embarrassed too. But I really admire some of the MDs who have had long-standing careers who fall upon their sword to go, you know what? Like I have a doctor in my thyroid book, my doctor, Dr. Forsman, and he'll tell you, he'll be like, look, I technically mistreated people for years because I just didn't know we weren't taught this stuff that I needed to know about this arena. And there were years where I probably hurt people without knowing, right? So it's no one's fault, but it is to say that opioids, I think we've all seen, are an absolute disaster. And unless you absolutely have to be a part of them in any way, run. Because I mean, the stories are incredible. People married, healthy, great family lives. Next thing you know, they're in an alley doing things they don't want to do. because this happened to them after a knee surgery or a wisdom tooth removal. And on that note, Todd, what's the state of the game now? Can I just be like, hey, give me some OxyContin, or has that really cracked down where they're not doing that anymore, or is it still a big problem?
It's it's that's a great
The
question.
legal part, not the illegal,
Yeah, and
yeah, doctor's
problem
offices.
the problem is, it's a surprising percentage of patients who ultimately become addicted to opioids because they had a surgical procedure, they needed opioids for a week, and as you mentioned, and now all of a sudden those opioids dry up, right? And especially nowadays in the current legal climate, there's no way to legally get those opioids. So you if your body's dependent and you're addicted, you're gonna,
Go to
many
heroin, something.
circumstances, you're gonna find a way, whether it's fentanyl on the street or heroin on the street or something like that. So yeah, it's amazing how it can change a life. Um, yeah, I will tell you as a physician and as a prescriber, I'm, the doctors are kind of stuck in the middle because there are those patients out there that are really suffering and for whom there at this point, there's not another option. I'll
Right.
go back to my, um, you know, kidney stone example. That that is, it's really severe, debilitating pain,
Mhm.
and nothing else will touch it. However, as a physician, I've got government agencies that are really limiting my ability to prescribe that, and rightly so for a lot of right reasons. But some people who are really suffering are kind of caught in the middle of this whole thing, and physicians are as well. So it's really, really difficult. That's why this search that we're doing for non-opioid solutions, I mean, that's why I come to work every day, because people are caught in the middle of this. There's either people on the one extreme that are addicted, or people on the other extreme who are in severe pain and can't really get the treatment that they need.
Okay, so I'm recalling like maybe 20 years ago, I we had a friend who went through knee surgery and they were given Vicodin and then they had kind of recovered, but we actually had to like pull the bottle from their hands. They started to use it for fun. And that I don't understand. I actually took a Vicodin once just to see what everyone was talking about. And I was like, this makes me feel like I have the flu. I don't know what. But anyway, and it was weird. We had a moment with him in the kitchen where we were like, hey man, what are you doing, dude? Like, this is what's going on here. This is headed in a you're not a pill popper. What's going on? And that was just Vicodin, right? That's not even considered probably an opioid. Um, Tough stuff. When you need it, you need it. Please get the help you need if you've gone in a wrong direction with this. But Todd, tell us where we can go. We'll put all the notes in the show notes, all of the links to connect with you. But where can someone go if they're like, I want another alternative for my family member, for me with pain management to see what's out there because maybe they're getting limited information from their own physicians. And then how can people reach out to you and find out more directly from you?
Yeah, great question. If you'll bear with me, I'm just gonna go back to one thing you said, and that is that you didn't like the Vicodin, but he really liked the Vicodin.
Yeah, totally. Yes.
Yeah, and
Yes,
and we're
loved it.
and our brains are so different, and there are people that and that's why people like you and me who don't get it when it comes to using these opioids. Our brains don't react to taking an opioid the same way other people's brains react to it. We're very, very
Interesting.
different. And there are interpersonal differences in the way our bodies respond to these medications. And and that's why it's really important not to be judgmental against people who can so easily become dependent and addicted. Walk a mile in your moccasins, right?
Oh, yeah. No,
That's one thing I
never
really,
judgment.
yeah.
That's sometimes, yeah, I don't know. I've had such long-standing friends with who've been either decades sober or whatnot, but seeing them go through either heroin addiction or some other things from the past. I saw people do amazing stuff, try to manage their heroin addiction by only smoking it, but then trying to like drink wheatgrass juice. I mean, all sorts of things to try to the level of things that some of our friends growing up went to. And thank God actually they did it then because then the pills weren't as widely available. They'd probably be dead by now. They ended up all getting sober. Um, it's like in their minds, the way it's been described to me is it's like they didn't even have a choice after the first time or two.
Yeah.
It didn't even have a choice. What? That seems so crazy to most people like you and I who are like, I can't imagine that. Or if it were me, no, I'd be able to stop. What is it? What's going on in there? Can you give us a brief rough down on like what happens, that makes someone just immediate addicted to something like that? Because that doesn't necessarily happen with someone taking one drink for the first time, or you know what I mean?
Yeah. Yeah, I wish I could tell you exactly what's going on a cellular level, but what I know for sure is, and what we do know for sure is that there are certain, we call them phenotypes, certain people whose makeup in their brain, their nervous system, the way those neurotransmitters are working in their brain, they're just more susceptible. And like you said, it's one time. You take one time and your body has rewired, your brain has rewired. And that's the scary part, right? Because we don't know when you come out of your surgery, am I one of those people or am I not one of those people,
Right.
right? There's no way to know.
There's no way to know. Um, maybe you can piggyback on this. Last week, I interviewed my doctor. We were talking about low dose naltrexone, which you probably have heard of with drug addicts, but in low doses, they use it for, people with autoimmune disorders and things like that, which is very interesting. But in the doses for drug addicts, what's the point of that? If they try to relapse, it won't affect them in the way that makes them keep doing it.
Yeah, that phrase is abuse deterrence. So
Yeah.
we're trying to find, and we're working on a lot of clinical trials right now with abuse deterrent medications, where you take some substance that makes it that blocks the effect of those opioids. So even if you took them, you wouldn't get the high, right?
Mm.
And we need to find ways to do that we can't work around, right? If I'm an addict and I really want to get a high, and a lot of these abuse deterrent things, I can find my way around those.
Oh, really?
And so developers are working really hard to find things that we can do. Even some people were working with surgical implants where there's a slow release of naltrexone, and you can't just get a pen and pull it out of you like you can if it's just under your skin. You'd have to do a surgical procedure to get it out of you. Things like that.
Okay. Okay.
Yeah, there are interesting ways that we do abuse deterrence. And
Hey,
I
by the way,
just
that's
keep,
just a fascinating term. I'm sure maybe some listeners too are feeling the same way. I've never heard that. Abuse deterrent sounds absolutely, I mean, it's a perfect term, but yeah, interesting. And I found the concept of that just in knowing about it from a Hashimoto's thyroid antibodies perspective, but then thinking about it in the other way. Um, there could be some really interesting headway there. Would there be a way, and again, maybe I'm thinking about this wrong because I'm not a doctor, but could it be like, well, you need to give opioids to someone for something serious, but then you introduce naltrexone later to perhaps get them out of a potential spiral? Am I not thinking logically there?
no, I think you're thinking very logically. And a lot of developers are looking at that route. Again, the difficulty is to find ways that there are no workarounds, right? Because a dedicated
Addict
person,
will find a way.
they'll find a workaround, right? But
Yeah.
but I just attended a conference yesterday that had a discussion about this very thing, where they're using the body's chemistry to basically break down the opioid more quickly, so that it doesn't produce the high, or give naltrexone with the opioid, and the opioid will only work at a certain dose. The naltrexone will then take over. I mean, there's so many different things that are being employed right now for abuse deterrence. It's really exciting time in the industry. The sad part is we're not there yet, but we really are getting close. I want people to understand we're getting close. We're going to figure this out. It's going to take some time. In the meantime, we just have to navigate this very difficult pathway of keeping people out of, excruciating pain, without turning them into addicts.
One last random sort of question before we close out here, which is something I learned that I was unaware of. So my fiance was afraid of the dentist, not because just generally people are afraid of the dentist, but because he literally can feel everything, and no matter how much they shoot him up inside his mouth, he can still feel it, right? And I'm thinking, that's crazy, right? And of course, every dentist office. So we go into my dentist, and my dentist said, hey, because my fiance's bald, he goes, hey, were you a redhead? Do you have any red? He goes, well, I have a lot of, redheads in the family. And then we talked to another friend who goes, oh, it's a thing with redheads. I have it too. They need to give me extra. And I was just like, what is going on here? Then someone just mentioned something about there being a gene and their propensity to have a lower threshold for pain or something. What's that about? Is there truth to this? Because I mean, even my dentist brought it up to my fiance in an appointment.
Well, the data on this is inconclusive. So I'm an anesthesiologist. I practiced for 25 years doing anesthesia, and there was always that thought in the back of your anesthesiologist's mind, if you're a redhead and you come in, I might have to give you a little bit more. But honestly, I think the most important thing to think about, there's not great data that says yes or no to that.
Okay.
But I think the thing to remember is that everybody's so different. And we all react to these things very differently for whatever reasons. Maybe it is a gene. Maybe it's just something that is part of our weird makeup of who we are, but we all do react very differently to these things. In fact, I'll tell you an interesting little story. These sodium channel blockers that I was talking to you about that are kind of interesting were discovered because there are certain people on Earth who don't have those channels, and they don't
feel pain.
They don't feel pain. And
that's this like let me ask you, years and years ago, I was a kid, and there was probably some 60 Minutes episode about a kid born where like they literally could have their hand on a hot stove and not feel that their hand was burning.
Yep.
I don't know. Is this related to that?
That's probably what we're talking about. Yeah. And
what is it called? What's this about?
Oh, I'd have to look that one up. But,
okay. But here's the thing. That's kind of dangerous.
It is kind of dangerous. But you can see that's one extreme, and the other extreme is your husband, and in the middle are all of us spread across that entire continuum, right? And that's what makes this so very hard. Not only because we're all so different, we experience pain so differently, but there are 1,000 different mechanisms for our body to experience pain. And it's really hard to hit every one of those. So I think it's funny. Some cultures handle pain much better than we do in Western culture. And I think we've gotten to this point as a culture where we think pain is bad no matter what. And pain, we're just not going to tolerate pain. We're going to do whatever it takes to not have pain. But in other cultures, they don't see that the same way. And their use of opioids and other analgesics is significantly lower, even though they have access to them than in our culture. So many variables. We could talk all day about the variables.
I know. I already have so many questions, but we've gone on for the time. Thank you so much for joining us. We'll put everything to connect with you in the show notes. Is there one website in particular you'd like to just voice right now to direct people to?
Sure. It's www.cenexel.com. And you can find me there.
Great. Thank you so much for your wisdom and all the work that you're doing to help people in chronic pain. And for everyone else, we'll see you next week.
Thanks so much.
Hey, thanks for listening. If you enjoyed this show, I would so appreciate you leaving a review on Apple or Spotify or wherever you get your podcasts. And to learn more about partner discounts on amazing products, visit elleruss.com/discounts.